Thank you, everyone. Thank you so much for the kind introduction and the invitation to speak here today. I'm sort of asked why I'm asked to speak on rural surgery, being from San Diego. So I'm going to give you a couple moments of why that is, and then some perspectives on training as a rural surgeon and getting more information and data. I don't have any financial disclosures for the talk today. So I did want to spend a few moments talking about why I am talking to you. I am at UCSD, and I'll get into it later, but we found we have a colleague here, so I'm the 2-hour hospital away from El Centro Regional that you just heard about. And so one of the things that I've learned over my career is that every urban center, every ivory tower is a very important part of rural surgery if the patients are willing to come, or if they have a complication, need to go. We work together in rural surgery. And I see rural patients from the desert region, from El Centro, et cetera. And then being so close to the international border, it gets even a little bit more confusing because we see international patients from Mexico and truly from around the world. That being said, I may be in an urban environment today, but I grew up in a very small town. My family still lives in a small town in Wisconsin and accesses critical access hospitals. And so from the patient side of things, I also absolutely understand the resistance of not wanting to go to a hospital, especially in a city, because they have no desire to go to the place where I work. Not because I work there, but because it's in an urban environment. I was at the University of Wisconsin, and so it's been a real pleasure to share the podium here with Dr. Jacobus. He was one of my trainee residents, and he was in the rural surgery tract there. And so I've had that perspective of training a rural surgeon in a rural surgery tract as well, and working with a lot of the rural surgeons through the Wisconsin Surgical Society, and getting to know colleagues and share patients back and forth from these rural centers to the larger urban center, and then back and forth that we've already talked about today. I'm also actually in a career transition, and I'm actually going to leave the University of California and go to the University of Missouri as the Division Chief of Trauma and Acute Care Surgery. And so I'll find myself once again in a very rural situation. So this is a nice transition talk that I'm not so far outside the rural realm again. And then we also had mentioned the American College of Surgeons Rural Surgery Advisory Council. And I've had the real pleasure of serving on that council actually as one of their members for, I think about the last 3 or 4 years. And I think their perspective and the American College of Surgeons' perspective is it is really important to keep the collaborations between academic urban centers with rural surgery, that it is truly the collaboration we've already heard about. So we'll talk a little bit about why the rural surgery workforce needs are different, which Dr. Jacobus clearly outlined for us today. What are some of those needs now, and what resources are available? And then I'll take the opportunity to talk a little bit about what role SAGES and some of the other organizations can provide for the rural surgeon. So as an example, Wisconsin is a fairly rural state. The urban centers are down in the southeast for the most part, in Milwaukee and in Madison. There's 127 hospitals in the state, and 58 of them, though, are critical access hospitals. And a good large amount of the population live a fair distance from a hospital. Across the country, we of course see this. There are large areas of our country that have very little hospital care access, and a lot of surgeons in these environments that don't have much support near them and are facing really difficult situations in caring for patients. So I like to say I am a rural-ish surgeon, and where my patients come from. So this is a blow-up map of Southern California. I think I can point on here. So just to orient you all, this is downtown San Diego, Coronado Island, where you go if you go to a convention there in San Diego. This is a heat map of a new IT EGS registry that we developed. And so it makes total sense that most of my patients are classic urban, homeless, et cetera, from downtown San Diego. But you can see we draw all around from the coast. This arrow here is pointing to a relatively large mountain range, which makes transport difficult for patients. So we actually will get weather and not be able to transport patients in. And I've experienced this in my training in Utah, in Pittsburgh, and also in Wisconsin, where transport, and you all as rural surgeons also will experience that. But out here is where Dr. Guang works in El Centro. And so you can see based upon our heat map, we do get a fair amount of patients transferred. And so I do take care of a fair amount of rural patients and have to deal with long transport times back and forth. And so we're looking forward to our collaboration moving forward in San Diego while I'm there. We know that most patients would prefer to seek care close to home. I loved that Dr. Straub was quoted earlier in the introduction. Dr. Straub and I actually trained together at the University of Utah. And so we actually over lunch were talking also about some of these issues that she has in her practice of patients not wanting to travel to a center, and she is the one providing care for them. Even if mortality is double what it would be in an urban center, half of patients would prefer to stay local, and 23% would stay local even if there's a 4-time increase in mortality. So what about rural surgeons themselves? Who can you call for advice? How do you get CME? How can you even stay current? And then there's extensive on-call time. How do they get a break? If they do need a break, do they have the resources to send their patients potentially to an urban center? Because burnout is incredibly important. We need to pay attention to that. And there can be limited medical resources. And if you can't provide the care, do you have a place you can send them? There's a whole list of things that causes discontent for rural surgeons, specifically looking at things that I want to address today: inadequate support and technology, difficulties in recruiting and retaining associates, feelings of professional isolation, difficulties in transferring challenging patients, and less specialty support. So how can we address these things specifically, in addition to the more global issues of burnout, time off, and some systemic policy problems? And I think this is really a place where SAGES can lead a really good role for rural surgeons and in the communication with urban surgeons. So here's the SAGES mission statement: to innovate, educate, and collaborate to improve patient care. And really, when we think about it, that's exactly what we've been talking about here today. So I think SAGES is much about community. There are not that many trauma surgeons around the halls of SAGES. I'm happy to share the podium here with another, but I do feel welcome here, and it's great to see the different perspectives outside of the clinical realm here at SAGES, and I think there is a very big role for rural surgeons in access and that collaboration within the organization. I don't want to walk you completely through the website, because of course you can do that, but SAGES provides a ton of patient information and guidelines and education for free. The videos, as I'm sure you've all have seen, are absolutely outstanding, and with any sort of internet access, anyone can get to this, and of course some CME as well. The SAGES Safe Cholecystectomy program is absolutely outstanding. I think this is particularly important for trainees, no matter where they're training or if they are trained in a rural tract, to have good resources to go to learn these techniques and walk through them in a technologically based place. And there's tons of committees and leadership opportunities within SAGES. So I would encourage you to check these out. It can lead to all sorts of engagement, even if you are in a rural practice with the internet. Jump online and have all sorts of collaborations. These patient information brochures, I think, are absolutely fantastic, whether you're a rural surgeon or an urban surgeon. I took a couple screenshots here of appendectomy, and I think these are great resources, especially if you're either strapped for time or with counseling patients. And I think these are a great benefit for free for rural surgeons, and the list of these patient information guides is seemingly endless in multiple language on the SAGES website. And then, of course, the SAGES TV, tons and tons of great video. And so if you're looking for education and say you don't have access to any, when I looked it up, my vision's too bad, but I think it's 722 educational videos on SAGES TV, and I was actually surprised to see how many trauma videos they were, so I'll be spending more time on SAGES TV myself. And this is what I wanted to mention about what I think SAGES is about now that especially we're back in person, and even if you're watching this at home, this is a really great opportunity and organization to collaborate and meet folks. So while Dr. Guang and I have for 2 years during a pandemic worked actually hand in hand without realizing it, we had the opportunity to meet last night. And so we actually share patients fairly regularly. We are the referral center for her patients if someone does need to come out or be backed up. And so this is the 2-hour road trip between San Diego and El Centro. And you can see the resources that I have at my disposal and that she has at her disposal, despite all of her industry connections, is quite a bit different just based upon hospital size. There's just a difference there. And so I think it's really important that the care of the rural patient and rural surgeon is based on a continuum, and we should work together. And I couldn't agree more that if the patient has to come to an urban center, it's great to move them back so they're closer to their family support systems for recovery. Of course, there's lots of other online forums that you can use, both in urban and particularly rural settings. The American College of Surgeons has communities, and I love when folks go on there and say, I have this challenging case, and kind of open it up to the world and can get really good feedback. So if you haven't checked that out, I'd encourage you to do so. I've been seeing more and more for the trauma folks in the AAST has a new platform, Connect, so most of the organizations are having these communication tools, so great places to stay connected. Doximity, Twitter, Facebook group, the International Hernia Collaboration. I love seeing the crazy cases that get posted there, and the conversation that goes back and forth on how folks would like to or suggest fixing that. And then I would really encourage rural surgeons to get engaged in their state medical and surgical societies, because it's another really great way to build those interpersonal communications and collaborations and sharing patients. So getting to meet people again will be good. What about CME? Because that can be a real issue if you're in a center that's not connected to an academic center. I think COVID really helped with this, right? Meetings are virtual or partially virtual, and so you can have access to get CME much more easily. Having come from the University of Wisconsin, I learned that all of their grand rounds are placed online for free. You can watch their videos of their weekly grand rounds, stay connected, see what that center at least is doing, and register for free CME, which is nice. And then the American College of Surgeons has all sorts, if you're a member of that organization, formal courses that are all eligible for CME as well. And then I just wanted to mention again the Advisory Council for Rural Surgery. The American College of Surgeons is very engaged in rural surgeons and collaboration. This council was established in 2012. It was the first additional advisory council in, I think it was like 20 or 30 years that they created. And so they really recognize that the rural surgeon is important for all of surgery, that if all the rural surgery hospitals close, we don't have enough capacity in urban centers for patients to travel to. So it is critical to our urban patients and our rural patients that we have robust, excellent rural surgeons. So I'm a very proud member of that. I'm happy to talk to anyone about that as well. So there are still a lot of current challenges in rural surgery, including surgical training, support for rural surgeons, and rural hospital closures, which are based upon federal policy. And so anyone who knows me, I can't do a talk without mentioning the importance of surgical health policy advocacy, so I'll mention that quickly. But first I'll start with rural surgery training. We heard more about this today, but you can see there's a number of programs that have developed programs. I was proud of the work that the University of Wisconsin did while I was there. That Dr. Jacobus is out in the rural community making great use of his training. That's fantastic to see. So we definitely need more of that. The Rural Surgery Advisory Council is working to build programs to place even for shorter periods of time. So if you're a rural surgeon, look for those opportunities from the college or otherwise. Training people is a great way to stay up to date. So I would encourage you to get involved with that as well. A few examples: the Gunderson Health System is a private hospital system in Wisconsin that has developed sort of a hub and spoke model for many years now. University of North Dakota has done this, more recently the University of Alabama. And then trying to keep rural surgery alive and to survive, national policy, who you vote, supporting the Surgeons PAC, to work on making sure our rural hospitals are supported as much as our urban centers are, so that all of our patients have excellent access to care. So I think the future is brighter for the rural surgeon. There's more technology, there's more connectivity. We didn't even really touch on the ability of telehealth, an ability for long-distance collaboration and consultation. We have better communication, we have better cooperation in practice and training between institutions, but we do have to do it together. Thank you.